Okay. All right. I think looks like it's okay. All right, guys. Sorry about that. As I say, sometimes, we are live. And so, this is live streaming TV. We're streaming to multiple platforms. So thank you all for hanging with us here. We've got the comment section here live. I think we've got it now. I just got a notification that we are live broadcasting on Facebook, YouTube, and LinkedIn. So again, without further ado, let's start this over. Welcome to Telehealth Tuesday. I'm Dr. Michael Bookhardt, your host. This is the go-to podcast for insights on modern healthcare and wellness solutions. Before I tell you about our very special guest, let's just do a little housekeeping here. We'd like to thank some of tonight's sponsors. Graphics are Chase, P5 Solutions, and always a dime a dynasty. So let's get right into it. I know we're a few minutes behind, and we're sorry about that. But again, this is live TV. Let's go to Dr. Ray Portis. I want to tell you about this young man. Is an amazing physician. He's a pulmonologist, critical care expert, and also a friend of mine. Dr. Ray Portis, who is originally from Jackson, Mississippi, received his doctorate of medicine degree in 2008 from Meharry Medical College in Nashville, Tennessee. He completed his internal medicine residency in 2011 and his fellowship in pulmonary and critical care medicine in 2014, both at the University of Mississippi Medical Center. He and his wife, Lanika Portis, reside in Madison, Mississippi, with their three children and a few dogs. I threw that one in there, Dr. Portis. So without further ado, I see that we've already got the slide up. So hear ye him. I want you to welcome Dr. Raymond Portis. Good evening, Dr. Portis.
How you doing?
Pretty good. How about you?
Hey, rough day. I voted, rounded, saw patients, and I'm here talking with you.
Well, well, we appreciate you coming on with us live on Telehealth Tuesday. We'll get right into it. Like I was saying before we got interrupted here, that we know today is voting day. So happy voting day to all of you out there. We are live, so please come on in the comment section and don't ask all your questions at once. Um, and so whoever your candidate is, we don't endorse any political candidate specifically, but hopefully you've chosen him or her. You've made your decision and have already been at the ballot box. Thank you all for doing so. So without further ado, Dr. Portis, let's talk about what to expect in the ICU. Could you give us, aside from the bio I read, could you just give us a little background? Tell us all about what you do and what your practice is about.
So, I'm Dr. Portis once again, and I'm a pulmonary critical care doctor. Um, on the critical care side is where I practice most of my ICU skills. Um, and then on the pulmonary side, that's where we do more of our lung health and diagnosis and maintenance of chronic pulmonary illnesses. Um, on the critical care side, I'm pretty much the gatekeeper of the intensive care unit. I'm an internist, pulmonologist, dibble and dabble in cardiology, um, minor illnesses such as heart failure, atrial fibrillation, and then some of your airway management with strokes and um, encephalopathies of viral etiologies such as like West Niles and herpetic and bacterial meningitis and things of that nature. In the intensive care unit, we take care of all levels of severity, minor severe diseases such as diabetic ketoacidosis or when diabetes gets out of control, to the point of GI bleeds, to the point of encephalopathies due to end stage liver disease, end stage renal disease, end stage cardiac disease, and end stage lung disease.
Mm-hmm.
And so it's a pretty broad net of what I do, but I also do this in conjunction with the consultants that actually specialize in these fields, such as the GI, such as the neurologist, such as the cardiologist. But I have to have a general knowledge base of these subspecialties that I deal with, so that when I deal with the specialist, we're still on one accord.
Hmm. Absolutely. Can you, Dr. Portis, could you just kind of walk us through a typical experience? What happens when a patient first gets admitted to the ICU? Maybe just kind of walk us through so the listeners understand.
Okay, so let's just, regardless of, I guess, the disease process, you have to meet a certain criteria to get into the intensive care unit. And that's critical care, which means your mortality or your risk of death just reached the threshold
Hmm.
that affords you the nursing staff and the expertise of everybody involved in the intensive care unit. Because there's going to be a different level of service that you get in an intensive care unit, because there are going to be a
Hmm.
whole lot of parameters that we're monitoring. Okay. And so one thing you have to realize and recognize is that once you get there, things are pretty serious.
Right.
Whether it's a GI bleed, whatever your process is, whether it's diabetes is severe enough to get in the ICU, whether it's um, cancer, a complication of your cancer, your chemotherapy,
Hmm.
you're all of a sudden critical. Okay. And so it starts with your assessment, which means this patient is going to need a high level of monitoring. They're going to need lab checks, lab draws, and a lot of attention. Okay. Can you hear me, Mike? Okay. I think we just lost him. But if you all are out there listening while he comes back, and the biggest thing with that level of service is that you have to work with the family to come up with a care plan. A lot of times when you're in the intensive care unit, because the risk of mortality or the risk of death is so high, you have to have goals of care and remembering what the family member may or may not want to happen during that time. But I think we're having technical difficulties right now, and I'm not sure if we're on. Okay, you can still hear me, so I'll keep talking. So you're in the ICU, your patient or family member is there, and they're needing our service. Um, what I offer during this time is the entire scope of my practice, which is, hey, we're going to do everything that we can do to keep you alive, keep you on this earth, keep your heart going, keep your kidneys going, etc. But we also have to look at the fact that we need to understand the underlying pathology that puts you in the predicament, right? Okay.
Right.
And sometimes the scope kind of twists because people feel that we have the answer to every medical condition within a pill or a service that we can give. And so once you're in the ICU, we come up with a care plan for you. And then we come up with a probability of you making it through this illness. And therefore, when you're there, it could be as grandiose as you would like, or it could be as peaceful as you like, if you understand what I'm saying. And it just depends on the probability and possibility of you make it through the acute illness. If someone comes in with a regular run of the mill pneumonia and needs the intensive care unit, things get a lot worse if they require mechanical ventilation, which is a ventilator, of course. They're a lot better. Your chances are a lot better if you don't require that. Um, and, like I said, a trip through the intensive care unit is always wrought with a high level of mortality and morbidity. And it just depends on the illness and the severity of that illness as to what is done, what is offered, and what can improve your chances of survival. Waiting on you, Mike. Can y'all still hear me out there?
Doc, can you hear me? Can you hear me?
I hear you fine. Yeah.
Okay, man. I'm sorry. I don't know what's going on. We sorry about that to the audience. I don't know what's going on. We haven't had those. It just kind of we're going in and out of the studio, but it seems I can tell that we're still live.
Well, I
So
think everybody could still hear me, so I was
I
still
mean, they
trying.
could, yeah, I could hear you on there. I tried to talk with our producer. Okay, but yeah, we'll keep it going there. So if you all can hear me, I see we've got some comments in there. Okay, okay, I see the comments coming in. Good
Yeah, I was
evening.
talking while you were gone.
Okay, man, I'm sorry about that, brother. You know, it's live TV. It was just kind of what was happening. We're cutting in and out here. I don't know if it's, who knows, maybe it's something going on with all the voting and it's a lot of people on the airwaves and
That's
I don't
fine.
know what it is. But as long as the viewers and the listeners can still hear you and get the information,
Right.
okay. All right. So I honestly missed those answers, but I think, but the question was, and we won't have Dr. Portis go through it again, but we see Miss Martha saying, good job. We appreciate that. Thank you all for joining. So Dr. Portis was telling us about, I'd asked him, walk us through a typical patient experience, you know, when you get admitted. So basically from, you know, once they come into the ER, you get admitted. And then if somebody's sick enough, then they go to the ICU critical care where Dr. Portis takes over. And so that's what he was answering. Okay, I think that we're back online fully here. So let's get back into it because I know we're kind of cutting in on the time. Dr. Portis, we may have to have you. We may have to have you back, like I say with a lot of our other guests. All right. So, what about what kind of could you tell us, about what types of things could the families expect? Like, because, of course, back, you've been critical care doctor for years. I've been a hospital doctor for years. And when COVID was at its peak and people were not allowed to visit, could you maybe just kind of take us through that, like how things are, kind of like what's the temperature now in the ICU? Like, are the patient family members able to visit? Can they stay overnight, or do they have to kind of come in for 30 minutes and leave? Like, how does that work with the family?
So I think during COVID, what happened is a lot of patient satisfaction surveys went out, which pretty much changed the way that we police the way that family comes in. Pre-COVID, there were designated visiting hours. During COVID, there was no visiting with a patient that had COVID. And of course, it was a pretty sad time during the 2019 to probably about 2021 because um, restrictions were strict and you had a lot of elderly people from nursing homes where you had pretty much nurses that kind of worked in various places however it got there. But these, due to the strict restrictions on visitation, a lot of people did not have visitation. And I think based on patient satisfaction, based off of that, it has morphed into more of a family oriented visitation in the ICU. The restrictions are a lot less right now. Um, I think that that's good because, you know, it's good and bad. I mean, to have family in the room all the time is good
Hmm.
because they get to get a bigger picture and more information. I think sometimes it's bad because now, post COVID, everything is available. The entire patient chart is available. People can look on there and see everything that they want to see, but they don't have a good understanding of medicine, right? So now you walk in a room and you get bombarded with 1,000 questions on every lab abnormality that the patient family member sees. Well, most of the abnormalities, if I pull your labs right now, you're going to have abnormalities, right?
That's right.
Right. And most of them are meaningless, correct?
That's right.
Right. Some mean something, most don't. And so now it's very burdensome because everyone has access to the chart. And
Hmm.
so you're explaining labs that, pretty much have no meaning when the big picture is the pneumonia or the stroke, and then you're worried about a hematocrit of 27 because it flags red in the chart, right? And
Hmm.
so now when you walk in a patient's room as a physician, you're almost put on the defense because you have to have all these numbers in your head and be ready to get bombarded with questions about things that aren't really pertinent to the admission or the mortality or the discharge,
Hmm.
and so COVID is it brought forth more visitation. It brought forth more information to the patient because people want to know what's going on. I think because nobody knew anything that was going on during this 3 year pandemic and people died. And so, I think though it's good to have patients there day to day if they can be reasonable, but, it also came with their ability to look at labs, and so you end up tying up a lot of time and energy on things that may not even be relevant to that mission.
Hmm. Yeah, absolutely. Absolutely. Well, and again, we appreciate everybody coming in and we're asking questions. We see, you know, we've got a question about the difference of being admitted to the ICU. Well, I guess, I'll let you answer this, but the answer would be that the ICU and critical care are basically the same. But that's one of the questions coming in. What would be the difference? Maybe we should say, if you don't mind, to our guest out there, can I rephrase your question to say, what's the difference between the critical care slash ICU unit and the regular medical floor? Like
Right.
what services are different?
Okay, and I'll be happy to expound on that. So, if let's just take your run of the mill diagnosis, which everybody may have heard of, should have heard of, is pneumonia, right?
Hmm.
So, if I come into the hospital with pneumonia, and it's me, it's Dr. Portis, I don't have any medical problems. Um, and I come in, my saturations are 94, and I've got an infiltrate, and I've been nauseated, vomited. I can't hold down PO medications, but it's a healthy looking Dr. Portis, right? I get admitted to the regular medicine floor, okay? Right? I've got a good blood pressure. I don't have any comorbidities, meaning cancer, HIV, very bad controlled diabetes, anything that would make that pneumonia complex. I
Right.
get admitted to a regular medicine floor. I get put on general antibiotics, okay? General antibiotics. I'm observed for 12, 24 hours to see if I get better, and then I get released home. That's a person that goes to the general medicine floor, okay? Now, let's just take the same Dr. Portis, okay? But let's give him bad diabetes, maybe let's, and I'm not speaking anything on myself, but give him a diagnosis of something like multiple myeloma on therapy, which decreases his immune system. Give him the same pneumonia. His blood pressure is a little marginal, and maybe 90 over 70, maybe 100 over 70, with a heart rate that's elevated above 100. And instead of being 96% SATs, I'm 90% SATs. And I look sick. I'm nauseated. I'm vomiting. I can't hold down any fluids. I'm the guy that goes to the ICU. And the difference is, what is the chance of these two Dr. Portises dying tonight, right? The one that has no medical problems and on no medications, chances are he's going to be fine. Put him
Hmm.
in. Let's make sure the antibiotics work. Let's make sure his cultures don't show anything that we're missing. He'll be
Hmm.
all right. Statistically speaking, he's going to be fine. But the other Dr. Portis that's immune suppressed because he's got, multiple myeloma on cancer treatment. He's got this low line blood pressure, signs of sepsis, etc., chances of getting a multi-drug resistant organism higher. Put him in the ICU because the chances are, if what we do in the next 12 hours doesn't work, he may require life support, non-invasive ventilation, such as BiPAP, or Foley, fluids, pressors. He needs to be somewhere where the nurse only has about one or two people to watch after, so that we don't lose that Dr. Portis. And that's
That's
the
right.
thing. Regardless to what your diagnosis is, there's levels of severity to it. And once you hit critical level severity, you need critical level monitoring. And that's when you go to the ICU.
Okay. Okay. We all right. Well, we appreciate you kind of helping to clear that up. So that was the answer to the difference between being admitted to the regular hospital floor, such as the med surge floor. You may hear it referred to that, or telemetry, or stepping it up to the ICU, aka critical care. Another question has come in about, what exactly is COPD, chronic obstructive pulmonary disease? Could you just maybe, briefly go over that and what that does to a person's lungs?
So, briefly, COPD, you can't cover COPD briefly,
Yeah.
but I will try. One of my worst experiences was covering COPD in a deposition, and I realized how deep it is. So let's just take COPD, chronic obstructive pulmonary disorder. That could be anything, okay? And so we'll start with what people think COPD is. COPD for the common person is a smoking related disorder. Would you agree?
Absolutely.
I smoke. Do I have COPD? Well, maybe, maybe not. So when you smoke, um, it releases inflammation in the lungs, okay? Mucus. These cells of your immune system release mucus in response to the toxins that are exposed to your lungs by any inhalant, whether it's smoking, vaping, some dusts, um, molds, anything, right? And based on your immune reaction in your lung, you develop obstruction. And obstruction is just the accumulation of inflammation, not bad cells, but inflammatory cells, and mucus and trash in the small airways of the lungs, right?
Mhm.
It can happen in the central airways in some forms of COPD, but we're talking about smoking right now. And so what you have is an obstruction, and it causes shortness of breath. Okay. And so that's COPD of a smoker. Um, we have treatments for that, which are inhalers, prednisone, sometimes antibiotics. And when it gets very, very severe, you get on oxygen. Um, that's smoking of lungs, best treated with smoking cessation. And one thing I will say about COPD is once the inflammation is gone, you're left with what you're left with. The lung is a lot like the brain. Once it's destroyed, it's gone.
Mhm.
Um, and the one thing that I will drive home to anybody listening is unlike, well, I'm not going to say unlike all organs, but the lung is an organ that loses its life over time. It's kind of like everything else in the body. So
Mhm.
in the spectrum of COPD, everybody should die with a certain form of it because you're going to lose your lung function over time, right? And so it's stated that about 150 cc's after you're about the age 40, 150
Mhm.
cc's of lung volume you lose over time, which under pulmonary function tests would kind of lead everybody to a certain degree of COPD as they
Mhm.
get older. The thing about smoking is you can accelerate that. And so if there's a smoker and you bring the smoker in and you say, okay, we're going to do some lung tests, right? And I do that. We have something called a forced expiratory volume over 1 second, which is what we grade them on. I can take that and tell you how old your lungs are, right? All right. So you come in there,
Mhm.
you do your pulmonary function test, and I say, this is how old your lungs are, and this is how old you are, right? And so if you're 60 years old, but your lungs are 80 years old, guess what? They're going to continue to lose function over time. And
Right.
so You may be 90 years old in lung function, but you may be 70 years old in age, right? And so the thing about smoking is you don't want to accelerate the loss of lung
Right.
in the face of your aging lungs, right? Because they're automatically aging. And then if you're smoking, you're accelerating that. And that's how you can have a person that's in their 60s with 80-year-old lungs, right? And you
Right.
keep trying to convince them to stop smoking because eventually, even without you smoking anymore, you're going to continue to lose lung function over time. I
Hmm.
guess that's what I'm trying to bring home. It's best done on a graph, but that's COPD of smokers, okay? Then you have emphysema of smokers. COPD is just inflammation, mucus, trash in the lungs, the difficulty breathing. You can kind of control that with steroids, etc. But there's emphysema where the lungs are just destroyed. You don't have the mucus and trash. You just
Hmm.
have the destruction. Okay.
Hmm.
And those are the ones that, you see the blue bloaters or the people that are on oxygen, humped over in the tripod position with a walker on a wheelchair, right? I think they have it worse because even if they stop smoking, they don't get better, right?
That's
Okay.
right.
And so, you know, those are the ones that usually present when the party is over and there's nothing you can do to get better. You know what I mean?
Hmm.
And
Absolutely.
I say that to them because it's like, hey, you're on oxygen now, and there's nothing we can do about it because the lungs are destroyed. If there's just trash in the lungs, you can clean that out and you can
Hmm.
stop smoking. But when they're just destroyed, they're destroyed. Now, that's COPD of smokers with emphysema and COPD. Now, let's just go back to the broad definition of COPD. It's anything that's obstructive pulmonary disorder. So you can put asthma in there, right? Asthma is COPD, right? Alpha 1 antitrypsin disease is COPD. If you work in a place with like rock grinding, silicosis is COPD. Um, Bronchiolitis obliterans pneumonia, COPD. Bronchiectasis, something that it's just the bad look of the genes. That's COPD, and so when you say COPD, it's a rabbit hole. But like I said, most people concentrate on the things that you can prevent, which is smoking. Everything else, occupational, asthma, which is your genetics, you
Right.
know, and sarcoidosis. Sometimes things like that you can't help, but they're still categorized. They're categorized under that umbrella. Okay.
I appreciate that, Dr. Portis. I know, and like you said, I know we opened up a big can of worm. That is a big kind of thing there. But I wanted to get to, if you don't mind, a few questions here because they're kind of pouring in. And you took care of a couple of because one person was asking some things about what test does one consider. Like you talked to us about the FEV1. You kind of went into that, how you all test for lung disease, and then the other questions about the effects of smoking, which all of us know obviously are bad, are terrible effects on our survival. So, okay, let's go to one from Mrs. Dot Portis. I'm sure you know who that is. Should I consider taking the an RSV vaccine, and what are the pros and cons?
Okay. RSV is a is a is it's a new vaccine. I don't even think it may be 2-3 years old, but it came after
The COVID.
it comes right after the COVID vaccines, right?
Mhm.
And so, as with all of my patients, and let's just be honest, we're in the South, and there's a lot of polarization politically about vaccines.
Mhm.
And so I'm very careful about who I recommend to get them and why, because vaccines have their side effects. Let's just be honest. I mean, you know, a couple of my colleagues were talking. We was like, let's just give 100 people a vaccine and give 1,000 people a glass of water and see who dies tomorrow. I guarantee you, somebody in each arm is going to die tomorrow, right? Did the water kill him or did the vaccine kill him? It doesn't
I can,
matter. But the person who took the vaccine is going to be on the news, right?
I can
Uh,
imagine which one of your partners said that. But go ahead. I
I'm
digress.
just
Go
saying.
ahead,
And so when I look at vaccines, and I also looked at the RSV, I looked at all of the vaccines and COVID, I studied them. And when I tell you the vaccines and COVID, they broke astronomical scientific barriers. But somebody had a blood clot, somebody died,
bro.
somebody couldn't remember something, somebody had a stroke, somebody had a clot, right? And it's because it was so new, those vaccines were completely questioned because of those side effects. But
Hmm.
RSV came out, and I sat with several drug reps who want all my COPD patients to have it, everybody with a lung disease to have it. But I said, let's go back and look at the side effects. It's the same side effect profile. It's going to be Guillain-Barré to a very, very small percentage. It's going to be a stroke. It's going to be some memory, anything. And so when it comes to RSV, COVID, the two that are the most, the newest that are out there, I give it to my most severe patients. If you have a severe COPD, severe bronchiectasis, in idiopathic pulmonary fibrosis, right?
Hmm.
If you're sitting on oxygen, and I think that a viral infection is going to tip you over to the point of losing your activities of daily life or your life, I recommend taking those. RSV has been around a very long time. It is the cause of a lot of morbidity in chronic pulmonary lung disease, especially the more severe you get. And I think that it's a part of good lung health if you have a lung diagnosis. Okay. If you have a lung problem, it is a part of your lung health to seek these um, vaccines, because at that point the risk of the side effect is the benefit of you not dying from, a superimposed complication due to your underlying lung disease. If you're on oxygen, if you're on antibiotics constantly, if you have 3 or 4 more exacerbations of COPD in a month, if you're in the doctor's office more than 3 times a year and your pulmonary doctor, yeah, I think you should have those,
Okay.
because they will prevent that possibility of that bad outcome. But
Absolutely.
one thing I will say is I probably catch RSV once a year. You know what I mean? And I don't think I need a vaccine for that. Some might. It's just like the flu vaccine. Some
Okay.
people are equipped to take the flu on, and some people aren't. But it's a part of my job that I have to have it. Do I think I need the flu vaccine? I could probably deal with it, but I'm not that old. But the older you get, the more you have to pay attention to things like that, because they can lead to complications that can
Yeah. And
increase your sickness and your mortality, which is
right.
death.
And absolutely. And I got my flu vaccine just today, by the way. Well, look, I know what the time is getting down, so I'm gonna try to run through a few, Dr. Portis. I know, well, we appreciate those answers to detail that, but I'm gonna kind of do a rapid fire. Maybe you can just kind of let's run through. We're gonna put a timer on you, brother. You like them politicians. They're gonna be on there tonight. You're gonna say yes or no, Senator, and say, well, But I'm just teasing you, man. We appreciate you coming on. So, okay, let's see. A lot of people smoke cigars now. This is a great question. How bad are cigars for your health? 90 seconds. No,
Okay, cigars. It's like 10 cigarettes. First of all, now
hmm.
one thing I can say is some people's lungs are equipped to take that irritant. Some people's aren't, and so yeah, does it put you at risk for developing lung cancer? Yes, over time. Certain amount of pack years affect your um, possibility of having lung cancer. Any inhalant that is not natural is not good. But I will say this: everyone should think of their lung as the ultimate immune system. It's one of the only organs that is in constant communication with the environment, right? And
That's
so
right.
you're inhaling. spores, scents, chemicals, everything all day. The only other organ that sees as much toxins as the lungs, to a lesser degree, is your mouth, your intestines, and your anus. Okay. And so I can't say that for everyone it's toxic. I would love for everyone to quit smoking and then I would be out of a job, correct?
That's right.
Right. But I'm here to take care of you in any complications that you have. It's sort of like drinking. Some people can, some people get liver failure.
Hmm.
Some people smoke and don't have a problem. Some people get COPD, bronchiectasis, lung cancer, and die. Um, the risk is higher in smokers for lung cancer. The risk is higher for smokers for COPD. But I would be lying to tell you that everybody that comes to get evaluated leaves with that diagnosis, you know. And I constantly tell people, the party's over. Some people, I cannot tell you to stop smoking because it's going to kill your lungs. I can only tell you that it's going to increase your risk of cancer. Genetics plays a great role in all this, and that's what I've seen over time. And
Absolutely.
that's why cigarettes are still being sold because everybody doesn't die from them.
There you go. That's a great point. Well, look, let's. I appreciate that answer. Let's go to one question here. If I'm suffering from cancer and I go to the ER for other issues, would you attempt to treat my cancer or strictly what I told you that I need treatment for? And would you consult my oncologist? So it seems okay. So
That's
I
a
think
great question because
yeah,
we
what's that?
deal with that a lot. So let's
Mm-hmm.
just say I'm gonna touch on three aspects of that. A
Oh,
patient comes in, a
and
patient
I'm sorry.
comes in.
Excuse
Go ahead.
me. No, I'm
Go ahead.
sorry. And they said example. I'm sorry. Example. If I had kidneys, so it sounded like this. The person is saying, if I'm suffering from cancer, but I came in with kidney stone, would you also treat my cancer, or just strictly what I told you, like basically the chief complaint, which is the kidney stone?
Right. So let's
Okay.
just touch on that because that's a very touchy subject. It's tough. Cancer is a battle. Okay. Cancer is a battle. We know it. Whether it's lung, kidney, colon, brain, whatever. So a patient comes in with a diagnosis of a malignancy and they have any problem, whether it's a GI bleed, pneumonia, or kidney stone.
Mm-hmm.
We treat it. I don't care if the patient is a do not resuscitate, meaning don't put me on a ventilator. You come in
Mm-hmm.
for a problem that's separate other than your cancer, we're going to treat that. Now, if you come into the hospital and you're on known treatment for your cancer, we do not consult your cancer doctor for a medical problem that is in the scope of our practice, right? So just because you come in for a kidney stone doesn't mean you get seen by your oncologist. If everything is okay with your cancer, there's no need to involve them, correct? Because there's
Mm-hmm.
nothing they're going to do. Now, if you're having a complication from your chemotherapy, guess what? I'm the doctor that takes care of that, not the cancer doctor, right? If they give you a chemo and you have a complication from it, one, we're not giving you any more chemo. Two, I'm going to reverse everything I can and treat what I can in hopes to get you back to your next dose of chemo. I think the biggest hurdle that we find is that sometimes when a patient gets that chemo, it's probably their last dose, you know,
Mm-hmm.
and there's a loss of hope or a question of hope that can only be, I guess, confirmed by their chemotherapy doctor because that's the person that they have the trust in. Okay.
Mm-hmm.
They want Dr. So and so to come in and tell them that it's over and, you know,
Mm-hmm.
I'm sick and I'm dying. I get that. But what people have to understand is most of the medical problems that you have from your cancer are managed medically in the intensive care unit in the hospital. It doesn't necessarily require the oncologist to come there because they've done their job by administering the best therapy for your disease, right? And so if it's just a kidney stone, a urinary tract infection, or a pneumonia, we're going to treat that. If it's a complication from your cancer, we're going to treat that. If it's the cancer, we're not going to treat that. That's when we'll call the oncologist and say, okay, the mass is bigger or the mass is doing X, Y, and Z. But usually that's going to be either a surgical issue or it's going to become a palliative issue, meaning
Mm-hmm.
comfort care at that point. Which it's not bad to have your oncologist to come in and weigh in and say, hey, you know, I looked at everything and the mass is worse and it's really nothing more we can do. The medical doctors are doing everything they can, and this is your treatment from now on. But yes, we treat anything you have going on. We don't usually treat cancer in the hospital or the ICU. There are very select and rare occasions that happens. But yeah, we all medical issues are treated.
Mm-hmm.
Usually not the cancer, but most definitely the cancer complications.
All right. Well, and we've got a few more, Dr. Porter. So let's power on through these. I'm putting the time on you now. All right, we touched on this cigar smoking being the new fad and how we touched. So, okay, I think we answered that. How detrimental it is to your lung health. You went through that and you educated us the fact that it's basically the equivalent of 10 cigarettes. And so over time, while it may not be as detrimental since they're not inhaled like that, cigars mainly just kind of being puffed on and blown back out. But you let us know that over time that they could be detrimental to certain people. Um, let's see. We have a question here. This is a 60 second. Any vitamins that you recommend, Dr. Portis? They're asking if you recommend any vitamins.
I knew
60
that was
seconds.
going to be a question. I don't. I will say this: any water soluble vitamin is not harmful. As far as what I do, anything that leads to better lung health is just going to be preventative.
Hmm.
And when I say preventative, it's going to be your vaccines, um, your decreased um, exposure to sick contacts,
Hmm.
exercise, breathing techniques, when there is a true lung pathology. If you have structural lung disease, the best I can offer is mucociliary clearance, which is going to be your inhalers, getting mucus out using incentive spirometry, volume expansion techniques.
Hmm.
I don't recommend the vitamins and etc. I don't I don't disavow them when they're not harmful to the body. But for me, it's going to be just keep your lungs clean and exercise them and weight loss exercise, pulmonary rehab, which is all about just cardiovascular and stretching them out to their limits with weight loss. But I don't have any vitamins that I just truly prescribe or endorse, but I don't discredit the ones that are not harmful.
Okay.
I've had several patients go off to the holistics, um, and to this day, I haven't had one that I believed in it, but I don't. I only see the ones that it doesn't work in, right? And that's what I see. I don't see those success stories. Therefore, I can't um, I can't really vouch for it.
Hmm.
But yeah, but my lung health is going to be vaccines when they're necessary, avoiding sick contacts when you have structural lung disease, etc., or when you get older, and especially getting your flu shot, getting your pneumonia shot in a timely fashion. These things are the things that I endorse.
Okay. All right. Perfect. And by the way, because we still are, we've got questions and comments pouring in. This has been one of the most exciting and interactive episodes. And Dr. Portis, we're definitely going to have you back on, man, because I'm telling you, man, you brought them out, brother. You brought them out. So I'm checking in with our producer, and I wanted to ask you. I know you're very busy, but would it be okay with you if we go maybe 8 minutes over? Do you think you might be able to give us another 8 minutes, Dr.
I
Portis?
can give you 8 minutes. I'm anxious to get to this election, so
I,
go
I,
ahead.
I know you are. All right. But we gonna. So like I said, we're gonna do rapid fire. So we're gonna pour through. All right. The Pierre Docs, and we say hello to Dr. David and Ardarian Pierre, Pierre
Personal
Docs.
friends of mine.
Absolutely. Personal friends of yours and mine. Excellent husband and wife, doctors that I train with, UMC and family medicine. So we thank you all so much for joining our celebrity guests. They are asking, what do you currently recommend for COVID vaccines as the number of infections have seemed to dwindle down?
And there are going to be people that disagree and agree with me on this one. And like I said, once again, my patients that have interstitial pulmonary fibrosis on oxygen, really, really bad bronchiectasis from chronic infections, COPD stage 3 to 4, those that are at risk of losing lung function based on a viral illness that will go awry. I
Mhm.
strongly recommend them to take these vaccines. At this point, the benefit of the vaccine outweighs the risk, which usually is quite small, of having a side effect. And when people think about these risks, I often want to tell them it's like going in a room of 1,000 people and saying three of you all are going to have an adverse outcome. And so the risk of you being one of the three from getting superimposed bacterial pneumonia or a viral illness that causes you to go on a ventilator and die is worth that, right? It's that chance that I want you to take because I know the debilitating effects of COVID could be. Now, at this juncture, COVID in the hospital is about like, I won't even I won't even put it next to the worst flu I've seen. It has
Mhm.
kind of become very infectious, but not very deadly. Okay. And so, of course, we're treating people, we're giving them the remdesivir, treat them for 4 days. They're coming off the oxygen well. They're not going on the ventilator and they're not dying. So I gravitate towards what's the severity of your lung disease and what's the risk of this actually turning into a pulmonary complication and causing you to either be uh, ventilator dependent or pulmonary cripple, etc. And so
Mhm.
right now, what I'm seeing, and we're in a very busy hospital, and I cover 3, 4 in the state. I'm not seeing a very deadly COVID. Okay, um, it's still infectious. It's still out there, but it's not the 2019, 20, or 21 COVID that we saw that was taking countless lives. You
Mhm.
know, I think that for your chronic patients, continue to vaccinate. For your healthy patients, it's your choice. Let's leave it at that.
All right. You heard it. You heard it there, folks. Well, let's keep on going. And I appreciate you saying that. We know that COVID was a terrible and deadly and depressing around those initial years. Let's see. Mika T was saying vitamin D. I think I might just quickly just jump in on that vitamin D. So Dr. Portis was telling us about, with the different vitamins, and he said there was nothing in particular that he was endorsing in terms of vitamins. And then we went to the vaccine, but to answer your question, and especially when it came to COVID, either treatment and prevention, zinc was one of the ones that was highlighted in the guidelines and CDC and all that stuff. And
Right.
so so what we were using was zinc, vitamin C, and vitamin C, vitamin D, Mika. So hopefully that helps to answer that question. All right, so we have another viewer here who said, this is a very interesting question. I'm going to put it up there. Would manual lymphatic drainage help to detoxify the lungs and help smokers recover? Interesting question. I put that up there. She's asking about lymphatic drainage that help detoxify the lungs.
Yeah, well, the lymphatics is your trash can, right? Everything that comes in the lungs, right? It gets dumped in the lymphatics. It goes into the inferior vena cava through the bloodstreams. But the lymphatics is an immune system like the spleen. Um, one, I, you know, to drain your lymphatics, it takes a thoracic surgeon to go in the thoracic duct. I mean, there are few things like a chylus pneumothorax, a chylus effusion that will cause someone to go in the lymphatic ducts. And the very limited exposure, but N equals 2 that I've had, nobody wants to go and do that.
Hmm.
I would be very weary of anybody that wants to drain your lymphatics because you smoke. But the answer is just unequivocally no. Think of your lungs as your intestine. Your intestine is mile and mile long in surface area, meaning it may not be but 30, 40 feet, but the surface area of that is the equivalent of a football field, right? And so your lungs are the equivalent of a football field. And so when you're inhaling toxins, the surface area of your lung is fighting off these toxins, right? And so the reaction is happening at the battlefield, not in the garbage can, right? So you can drain whatever toxins go in your lymphatics, but your body's got doing a great job of that anyway, right? Because
Hmm.
once it gets in your lymphatics, it's going out. The problem is the damage that happens in your lung is on the battlefield. So when the smoke enters your lungs, there's an inflammatory reaction that happens in the alveoli. You can look that up in the central bronchioles, which is your bronchial tubes, and in the capillaries, which are the blood vessels that get oxygen to that get the oxygen to your blood vessels. And so, yeah, the lymphatics are a good drainage for the trash that's left over, but I don't think draining it would definitely not prevent you from having lung damage from smoking.
Hmm.
Okay.
Okay. And
Yeah.
yeah, that was a very interesting question, and we appreciate that. And I think the young lady that asked the question, I know her personally, and I know part of her practice, Dr. Porter, she does a lot of massage therapy and
Yeah.
different things, and then she also does a lot of for breast cancer survivors and different people that
Right.
have had like, BBLs and cosmetics. So she does that kind of outer
It will get rid of
massage.
toxins now.
Yeah, so yeah, to get rid of basically the gross on a gross level, the toxin.
Yeah,
Yes,
it'll
and
get rid of toxins. It just won't get rid of the damage that's done on the front lines. You see what I'm
that,
saying?
absolutely. A couple of more questions here, real quick. Dr. Portis, are bronchs, so what they're asking about bronchoscopies, and he can tell you, Dr. Portis tell you what that is. Are bronchs beneficial for these types of patients in the ICU when they're on ventilator? And when you say these types of patients, she might
I
have asked
can,
that a
I
few
can
minutes
just
ago, but
so
yeah, wanted to
listen.
talk.
So you get a patient on the ventilator, right? A bronchoscopy is only useful
Hmm.
if there is a mechanical issue from mucus being secreted in that airway to the point where you're not getting the air in the lung like you need. So if a person has real bad pneumonia, okay, and they're making tons and tons of secretions, and those things build up down there in one of the part of the lung, and it collapses, I can go and suck that out. Okay, that's one. Um, that's pretty much the only area that a bronchoscopy is useful once a patient is on a ventilator. Usually, if there's some sort of cancer, I can diagnose it. I can't fix it. If you're on a ventilator for a cancer, I really can't help you. I can say, hey, it's a cancer. Um, we can diagnose the reason a patient is on a ventilator. Some people's airways just have no tone. Okay. You can go down there and you can look at that. Um, oh, if there is a possibility of a pneumonia, I could go down there and I can help to diagnose that with samples, right? So if a person is on a ventilator and they all of a sudden start doing worse, I can diagnose a infection that we may not have thought about.
Hmm.
And those are the few instances when a patient is on a ventilator that a bronchoscope would be useful. Now, sometimes we need it just to intubate the person. If they have swollen airway, burns, we go down there for burns quite frequently just to assess the airway and see what the damage is, especially if there's an inhalant, such as like ammonia or burn. You smoke a cigarette while you were on oxygen. But those are pretty much the only times we use that. And to remove a foreign object, you swallow a toothpick, chicken bone, etc. Peel, you know.
Hmm.
Mhm.
Excellent, excellent. Okay, we appreciate that answer. I think Ms. Jasmine, the one who was the young lady asking about lymphatic drainage, she said, made a comment that I'll put that up there for all to see. I got my son off 8 different medications or asthma medication using manual lymphatic drainage. That's very interesting, Jasmine. That's phenomenal. I think at a later date we maybe we'll be able to explore that a little more. We've got time for one more question, man. They'll tell you they're coming on in, Dr. Portis. Um, and Nurse Phillips was saying, okay, when she said in the bronchoscopy in those patients, she was referring to the emphysema patients. I've always wanted to know the benefits of bronchoscopy, and so thank you for answering that, she says. All right, we've got time, ladies and gentlemen, for one more question. One more. I had plenty of pre-prepared questions as always, but we've had such fantastic input tonight on Telehealth Tuesday that we're just going with everything you guys want to know. So, okay. So we'll let that one last one come in. Dr. Portis, as we do each and every Tuesday, we're going to go ahead and wind up. But like I said, one more question. That's fine. Would you mind telling us, Dr. Portis, where we heard you say that you're at 3 or 4 different hospitals in the state? Would you mind letting viewers know where they can find you if you're taking new patients? You know, the name of your practice and what you're working on, all that good stuff.
Okay, I'm at Jackson Pulmonary Associates. I'm in the Colonnades building on the second floor at Baptist. Um, I currently work in the intensive care unit there at Baptist Hospital. Also doing consults on the floor. I take consults on my patients as well as we take those from the community. Um, I work at Merritt in Madison. Um, in the intensive care unit there. I see consults there as well. But of course, my clinic is funneled towards the Baptist Colonnades. And currently, that's it right now. We just lost our merit ranking contract, so I'm no longer at Merit General. And so pretty much primarily at Baptist, Merit Health in Madison, and we take call over the greater metro Jackson area, Select, St. Dominic's, River Oaks, etc.
Awesome, awesome. Somebody said JPA in the house. Very informative. Great job, dear friends. Well, we thank y'all. We thank the Pierre Dawson, and thank you.
You're
Thank you so
welcome,
much.
man. I appreciate you having me.
Absolutely. We truly appreciate it. It's been quite a pleasure, and we've learned so much about what to expect in the ICU here on Telehealth Tuesday with Dr. Ray Portis, Jackson Pulmonary Associates. He just let you know where you can find him. Hopefully, you won't be in the ICU or won't have but should you run into him, now you put a face with the name.
There
So
you
thank
go.
you. Yeah, absolutely. Thank you so much again for watching Telehealth Tuesday. And as always, you never know who or what you're going to see. And so next week we've got Captain Christian Vance on community engagement, and I know a lot of you know that guy. You don't want to miss him, Captain Christian Vance. He's a good friend of mine. I know you know him too, Dr. Portis. I think some of us
Yeah.
we share we share the same barber who's also related to you. Uh, so again,
That's right.
thank you so much. That's right. So thank you so much, everyone, for getting out the vote, for going. If you haven't voted, well,
It's
shame
too
on
late
you.
now.
It's too late now. But again, this has been another fantastic episode of Telehealth Tuesday. You can find us here every week, every Tuesday, 7 o'clock p.m. Central Standard Time to 8 o'clock. You can find us on YouTube, Dr. BTV, DOCTOR BTV. You can find us Good Faith Wellness Center on Instagram and Facebook, and also Dr. Michael Bookhardt on LinkedIn. And again, next week, Dr. Christian Vance. Thank you again to Dr. Portis. Everyone, you can tune in now. Go watch that election. And until next time, always remember, true wealth begins. Hello, I'm Dr. Michael Bookhardt. Come join us at our newest clinic location at Good Faith Wellness Center. We provide compassionate health care for your entire family, from virtual visits to office appointments. We're committed to providing the best care. We accept all insurances, and we provide monthly wellness plans. Let's start your family journey to a healthier, happier life. Schedule your appointment today, and remember, true wealth begins with good health. Hello, I'm Dr. Michael Bookhardt. Come join us at our newest clinic location